So can't hear you.
Right, sorry for the delay. So we are doing the MCQ question number 1, surgery indicated uterine fibroid. So the concept you need to understand here, whether you want to treat the patient or not. Of course, if the patient is symptomatic, we need to treat. The symptom could be, or maybe heavy bleeding or pressure symptoms, maybe subfertility, abdominal discomfort, right? So urinary discomfort or frequency, wherever. So they depend on the position of the fibroid, the symptoms might vary. So any kind of symptoms, we need to treat them. That is the answer. Any kind of treatment or symptoms, we need to treat them. So in case of treatment, you should decide what kind of treatment. Are we going to do the surgery, or are we going to treat them with medically? Let's say for example, if the patient has only bleeding, right? So then you can think about the treatment with medically. So this medical treatment can be two type. One, so when you treat them with medically, that will reduce the bleeding. Second one, it might reduce the size of the fibroid. Do you understand what I'm telling? So the medical treatment can be reduce the fibroid as well as the bleeding. So some medical treatment will not reduce the fibroid size, but only it will reduce the bleeding. Some medical treatment will reduce both. Say for example, if you give the OCP, if you give tranexamic acid, that will reduce the bleeding, not the fibroid size. But if you give GnRH analog, that will reduce the bleeding as well as fibroid size. Do you understand? So there are two types of medical management which can be used to reduce the bleeding as well as size of the fibroid. Sometimes some patient might need symptomatic patient might need surgical management. Like for example, if it is a fibroid in the submucosal area, right, and also patient wanted to become pregnant, right, as we know, this submucosal fibroid, right, will prevent the implantation, right? So this is your uh, endometrium. So you are having a fibroid here. So this fibroid will prevent the implantation. So obviously you need to remove this fibroid. Otherwise, she can't become pregnant. She can't become pregnant. So she needs a surgical management. right? So some condition might need surgical removal, some condition might need might need medical treatment. So here we'll read this question and come to the answers. So the red degeneration during pregnancy, what do you think? Is it indicated? So in red degeneration, especially in pregnancy, you should not touch the fibroid. The reason is during the pregnancy, the uterus is getting high blood flow. So if you cut the uterus with pregnancy, definitely there will be a massive PPH and you may have to go for a hysterectomy. When the baby is inside the uterus, can you cut the uterus? Definitely you can't, right? So that will affect the fetus as well as the pregnancy. So during pregnancy, if it is a red degeneration, which can cause severe pain. So for the pain due to this fibroid, we are not doing any surgical intervention. What we are doing is we are just giving the analgesia, pain relief. The pain relief is only treatment modality for the red degeneration during pregnancy. We don't do surgery for a fibroid degeneration during pregnancy. So that is false. Oligomenorrhea, so obviously the fibroid can cause menorrhagia. Oligomenorrhea is less likely, isn't it? So if the patient is oligomenorrheic, no bleeding, then are we going to do surgery? No, no need, right? So don't, false. Urinary retention, can fibroid cause urinary retention? Yes. Why? If the fibroid is in the lower part of the uterus, somewhere here like this, right? So the bladder is anterior to the uterus, right? So if you have a large fibroid here, this large fibroid might compress the bladder neck. Once the bladder neck gets compressed, the urine can't come out. So then patient will develop urinary retention. If the fibroid causes urinary retention, obviously you need to remove the fibroid. Otherwise, patient will have repeated urinary retention and urinary symptoms. So that's why what you have to do is you have to remove the fibroid. So urinary retention is an indication for the surgery, right? So can you have the increased frequency by fibroid? Yes, because if the fibroid is in the upper part, right? If the fibroid is in the upper part, let's say like this. If the fibroid is in here, upper part, what will happen? It will compress the bladder. Once it compresses the bladder, bladder will not enlarge, distend. It will prevent the bladder distension. Once the bladder distension prevented, what will happen? Even with a small volume, patient won't micturate. So they will have frequent micturation. So increased frequency is a feature of it's a symptomatic feature of some fibroid. So urinary retention, we need to do the surgery. Submucosal fibroid in subfertile woman, yes, we discussed. If it is a subfertile woman and fibroid is in the submucosal region, obviously you need to do the surgical intervention, true. And 3 centimeter fundal fibroid in postmenopausal woman, actually this fibroid is estrogen dependent one, right? The fibroid is estrogen dependent one. So when the woman has estrogen, the fibroid will grow. In the absence of estrogen, fibroid will shrink. Okay. So once women reach menopause, what will happen to the estrogen? Will come down. So the fibroid blood flow will reduce and fibroid growth will reduce and fibroid size will reduce. So the fibroid will undergo degenerative changes after menopause. Right? So what kind of degeneration will occur in fibroid in postmenopausal woman? That is called hyaline degeneration or white degeneration. In pregnancy, you will get red degeneration. In postmenopausal lady, you will get hyaline degeneration or white degeneration. So you will get white degeneration and shrinkage of the fibroid after menopause. So if it is a 3 centimeter fibroid in fundus in postmenopausal bleeding, or postmenopausal lady, will you do any intervention or can you wait? What do you think? You don't need to do anything because the fibroid will shrink further. Do you understand? So answers are false, false, true, true, false. Question number 2. Ovulation induction by clomiphene known to cause. So as we know, clomiphene is an ovulation induction agent we are using for subfertility treatment, right? So we should know a few things, the concept about the ovulation induction, right? So we need to induce the ovulation. So ovulation under hypothalamo, pituitary, ovarian axis, right? So your hypothalamus will secrete the GnRH, then pituitary will secrete the FSH, then follicles will stimulate, the follicles will release the estrogen. That estrogen, right? That estrogen will have two functions. One is systemic function as well as the uterine endometrial stimulation. Same time, this estrogen and progesterone will have the negative feedback inhibition to the pituitary and the hypothalamus. Negative feedback inhibition to the pituitary and the hypothalamus. Why is that? Once the follicle start to develop, there should not be any new follicular development. So FSH will be inhibited by the estrogen. That is the negative feedback inhibition as we studied earlier, right? So what we are doing in ovulation induction, we are using the clomiphene citrate. So what is this clomiphene citrate? Clomiphene citrate, so there are estrogen receptors in the pituitary and hypothalamus, right? In this estrogen receptors, right? In these estrogen receptors, what will happen? The estrogen will come and act on the estrogen receptor. So this estrogen, right? Estrogen will act on the estrogen receptor. Once it acts on the estrogen receptor, that will inhibit the FSH secretion. That is your negative feedback inhibition. So in clomiphene citrate, what we'll do is a estrogenic antagonist. Actually, what is the meaning of antagonist? It's resist the action of estrogen. So when you give the clomiphene citrate will inhibit the estrogen receptor which is present in the pituitary as well as the hypothalamus. Once the clomiphene citrate bind to this receptor, what will happen? Actually, this is a estrogen antagonist, but it doesn't have action as estrogen. So what is actually doing? It's inhibiting the receptor, but not exerting the action as estrogen. So the clomiphene citrate will inhibit the estrogenic receptor, so there won't be any FSH inhibition. So the FSH secretion will not inhibited. So what will happen to the FSH secretion? It will goes up. If the FSH secretion goes up, what will happen? That FSH will stimulate the pituitary and follicle will stimulate. So what is the action of clomiphene is, that is inhibiting the inhibitory action of estrogen at pituitary and hypothalamus. Do you understand what I'm telling? Right? This is inhibiting the inhibitory action of pituitary, estrogen at pituitary and the hypothalamus. Right? So when you give the clomiphene citrate, that will increase the FSH. When the FSH secretion goes up, there are problems. What are the problems? One, the FSH will stimulate more than one follicles. Once more than one follicle stimulated, there will be more ovum. So more ovum can cause multiple pregnancy. One complication is multiple pregnancy. Second one is when you have more and more ovum release, that will release more chemical mediators which can cause extravasation of the fluid and leaking of the fluid into the interstitial space, causing edema. That is called ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Okay, so which can cause ovarian hyperstimulation syndrome, which can cause multiple pregnancy. And also, as we discussed, this clomiphene is an anti-estrogen. So this anti-estrogen can have anti-estrogenic activity in the endometrium as well. So it has mild endometrial atrophy effect also there, right? And also this clomiphene has some other complications, so side effect like dyspeptic symptom, abdominal bloatiness, blurring of vision, right? So these are side effect of clomiphene citrate. Right. Okay. Now the question is regarding the ovulation induction by clomiphene citrate, which can cause multiple pregnancy. Obviously true, because it will stimulate more than one follicle. So then there is a chance of two baby formation. But if it is natural one, there will be one follicular development. That is called monofollicular development. Natural one is always monofollicular development. Right? Very rarely we will get multifollicular development. But in ovulation induction, it's not well controlled method, so there will be a chance of having more follicular development. So multiple pregnancy risk is high too. Ovarian hyperstimulation syndrome, yes, it's one of the complication of clomiphene citrate ovulation induction. And visual disturbance, that is one of the side effect. And endometrial carcinoma. So endometrial carcinoma is not a complication of ovulation induction, right? Because endometrial CA is a risk when we expose to unopposed estrogen therapy or unopposed estrogen. When the endometrium is exposed to unopposed estrogen, but actually the clomiphene is anti-estrogen. So it can't be a risk factor for endometrial CA. Do you all understand what I'm telling? So clomiphene citrate can't be a risk factor for endometrial CA. That is false. Premature menopause? No. If you induce the follicles, you might think a lot of follicles will utilize and it might finish a bit early. It's not like that, right? So your ovulation induction might cause 2 or 3 follicular development, or maybe more than, maybe 10 follicles. That will not deplete much. So that won't be a risk factor for the premature ovarian failure or menopause. So false. So the answers are true, 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 false, false. True, 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 false, false. Right. Question number 3 regarding copper T IUCD, contraindicated in congenital heart disease. Copper T IUCD is contraindicated in congenital heart disease. What do you think? Somebody asked more follicular development, more estrogen. Can it be a risk factor for endometrial CA? Actually not. Because once the follicle develop, what will happen? The follicle will rupture and progesterone will come. Once the progesterone comes, it will protect the endometrium, so it can't be a risk factor, right? So that is not right. Another question is COCP is contraindicated in fibroid due to estrogen? No, false. Right? So if you came to my class, you won't answer like this, because COCP, combined oral contraceptive pills. So what is combined there? It's progesterone. So once you have progesterone, that is protect the growth. So then it won't cause fibroid growth. So it's not contraindicated, right? So question number 3 regarding copper IUCD, contraindicated in congenital heart disease? No, it's not. But if it is a severe valvular heart disease, it's contraindicated. Usually we don't put intrauterine contraceptive devices for severe valvular heart disease patient. That is not recommended. But other congenital heart disease, this is the safest method for contraception. The reason is hormonal contraception always causing fluid retention and heart failure risk is high. But non-hormonal long-acting contraceptions are best recommended for the congenital heart disease. So copper IUCD is one of the best method for the congenital heart disease. But if it is a severe valvular heart disease, usually we don't recommend for the intrauterine contraception. But we have to mark it as false. Contraindicated in congenital heart disease, false. Can be used as emergency contraception? Yes, this is the best contraception. We can use up to 120 hours. It means 5 days, right? So once you put in, there are two effects. One, the copper will be act as a spermicidal agent and it will prevent the implantation. So copper IUCD is one of the best method for the emergency contraception, right? We can use up to 5 days even after unprotected sexual intercourse. It reduced the menstrual blood loss, actually false. Usually if you put the copper IUCD, bleeding will be more. The reason is it will irritate the endometrium and causing chronic endometritis. The reason is chronic inflammation into the endometrium. It's a foreign body which is in the endometrial cavity which irritate the endometrial cavity, which can cause bleeding. So chronic endometritis, usually this copper IUCD patient will have irregular heavy bleeding, right? So that is a common side effect of copper IUCD. The reason is this can cause a chronic endometritis. So it reduces the menstrual loss, false. Increase the risk of PID. What do you think? Increase the risk of PID. Yeah, that's true, right? Because the risk of PID will increase because you are putting the IUCD into the endometrial cavity and the threat will be outside, right? So you might see I think you might know how will be the IUCD, right? So this is your uterine cavity, uterus. This is your cavity. You are putting the IUCD here. The loop will be outside the cervix. So now the thread as well as the loop is going to be a inoculating organ. So it's a tract for the ascending infection. So it's a risk factor for ascending infection because the vagina has a lot of organism. These organisms can easily ascend through the thread to the endometrium as well as the fallopian tube. So it's a high risk for uh, infection, right? So it's increase the risk of PID, that is true. And for the question number, stem number E, increase the risk of endometrial CA, obviously false. It will not increase the risk of endometrial CA, right? It will not reduce the risk of endometrial CA. So the answers for question number 3 is false, true, false, true, false. Right. Question number 4. Sequelae of untreated pelvic inflammatory disease. Sequelae of untreated pelvic inflammatory disease. Infertility. What do you think? Right. So if it is a pelvic inflammatory disease, the pelvic inflammatory disease is ascending infection from the cervix to peritoneum. So cervicitis, endometritis, salpingitis, oophorytis, peritonitis. It's ascend through the cervix, endometrium, tube, ovary, and the peritoneum. So when you have an infection, this infection can be acute infection or chronic infection. Acute infection will cause sepsis. Chronic infection will cause a lot of sequelae. So chronic infection can cause pain, can cause fibrosis, narrowing of the tubes, right? Adhesions. So which cause severe dysmenorrhea, painful bleeding, dyspareunia, painful intercourse, heavy bleeding, causing tubal occlusion, which is a risk factor for the subfertility as well as the ectopic pregnancy. Do you understand? Right. So here, sequelae of PID, infertility, true or false? Obviously, it's true because which can cause dyspareunia, which can cause tubal occlusion, which can cause endometritis and Asherman syndrome, endometrial fibrosis. So it can cause infertility, true. Secondary amenorrhea, what do you think? Secondary amenorrhea. PID can cause secondary amenorrhea. Yeah, Sanjeevan, can it cause secondary amenorrhea? Yeah, which can cause secondary amenorrhea. So the chronic PID can cause both, can cause heavy bleeding, at the same time can cause amenorrhea. The reason is if you have endometritis, chronic endometritis, your endometrial tissue will get damaged and replaced by the fibrous tissue. Once the endometrial tissue replaced by the fibrous tissue, how do you call that? What is the syndrome that is called?
Asherman.
Asherman syndrome, right? So if it's an Asherman syndrome, patient will present with amenorrhea. So secondary amenorrhea can be a sequelae of PID. Okay, right. Tubo-ovarian abscess, of course, which can cause abscess if it is an ascending infection. And chronic pelvic pain, yes, as we discussed, which can cause chronic pelvic pain. Endometriosis. So the pathophysiology of endometriosis is totally different. Endometrium is implanted into the other area, so it could be due to retrograde menstruation or maybe due to transcoelomic metaplasia, right? Coelomic metaplasia. Those are the two pathophysiology, not because of the infection. So that is false. So answers are true, false. Endometriosis produce nodularity in the POD. What is endometriosis? Presence of endometrial tissue outside the endometrial cavity. Presence of endometrial tissue outside the endometrial cavity is endometriosis. Do you understand? Right. So if the endometrial tissue present the outside the cavity, depend on the area where the endometrial tissue present, the symptoms and consequences will vary. So if the endometrial tissue present in the bladder, patient will have hematuria, painful urination. If the endometrial tissue present in the rectum, patient will have dysphagia, painful defecation, and cyclical PR bleeding, right? If the endometrium is in the pouch of Douglas, then there will be a fibrosis, nodular lesions, adhesions, right? Adhesions. Those are consequences of inflammation due to menstrual bleeding outside the cavity, right? Those are the sequences. So here, endometriosis produce nodularity in the pouch of Douglas, of course, because if the endometrial tissue present in the pouch of Douglas, then there will be a shedding of endometrium into the pouch of Douglas. That is an inflammatory process which convert to chronic inflammation. Chronic inflammation will form adhesions, fibrosis, and nodular lesion. So that is possible. Nodularity in the POD can be. Commonly results in obstruction of fallopian tube. What do you think? Commonly results in obstruction of fallopian tube. Actually, we have to take it as false. The reason is the word commonly, which can cause obstruction, but not commonly. Right? So very careful when you do the questions. Right? Commonly results. Commonly results means if somebody has endometriosis, they commonly they will have tubal occlusion. Not like that. They might have tubal occlusion. That is not a common presentation. There are so many consequences in endometriosis. One of the consequences is tubal occlusion. That is not common consequence. So which might cause. So that is, we have to take false as they mention is commonly. Causes anovulation, endometriosis cause anovulation. What do you think? That's false because there is no problem in the ovary here. In endometriosis, there is no problem in the ovary. Okay, so problem is endometrial tissue presence outside the endometrial cavity. So which can cause fibrosis, adhesion, right? So occlusion of tube. So there is no problem with the ovum development. Okay, so which won't cause anovulation, right? So that is false. Characteristically regress in pregnancy. What do you think? Characteristically regress in pregnancy. Yeah, somebody asked if it is an endometrioma, will it cause an ovulation? No. Even if it is an endometrioma, endometrial tissue present in the ovary, that is called endometrioma. Even endometrioma will not cause an ovulation. They will ovulate, but the ovum will be low quality ovum. Right? There is no problem. Right. So in endometriosis, characteristically regress in pregnancy. So as we know, the endometrial tissue should be here, but it's abnormally present in the peritoneal cavity, abnormally present in the fallopian tube, abnormally present in the ovary. So this is your endometrioma. So because of the abnormal endometrial tissue which is present outside the cavity, what will happen? That endometrial tissue will grow with the estrogen, and later what will happen? That endometrial tissue will undergo shedding off. Once it is shedding off, that is your menstrual bleeding. During the shedding off period, there will be inflammatory reaction. That inflammation will lead to chronic inflammation. That chronic inflammation will lead to fibrosis, adhesions, and occlusion, all pain, all kind of consequences. So where is the problem? Problem is when the endometrium shed off. If the endometrium shed off, definitely there will be an inflammation. If you have inflammation, definitely you will have all kind of sequences. So if you want to treat this condition, what you want to do, you have to stop the shedding off of this endometrium. Do you understand what I'm telling? If the endometrium shed off, definitely they will have inflammation. So you need to stop the inflammatory process. You need to stop the shedding off of this endometrium. So if you want to stop the shedding of endometrium, then they should not have amenorrhea, should not have menstrual bleeding. You need to stop the menstrual bleeding. Whenever they menstruate, the endometrium will shed off, not only inside the uterine cavity, also outside the cavity as well. So the management aim is anovulation, not anovulation, amenorrhea. If you keep the mother amenorrheic, the endometriosis or endometrioma or endometriosis will subside. So if the mother reach menopause, what will happen? What will happen if the mother reach menopause? She will not have any estrogen, no proliferation, no shedding off, no bleeding, no inflammation, no pain. So after menopause, the endometriosis will settle down. So if it is a pregnancy, do you have endometrial shedding off during the pregnancy? No. No endometrial shedding off. If the endometrium is not shedding off, will you have inflammation? Because when the endometrium shed off, ischemia, inflammation and pain. So if the endometrium is not shedding off, will you have inflammation? No. Will you have pain? Can you have fibrosis? No. So then if you don't have any inflammation, your endometriosis will set down. So pregnancy, during the pregnancy, the endometriosis will get improved. In menopause, endometriosis will get improved. So if you want to treat a patient, then what you want to do, you want to make them amenorrheic. Whatever the means, if you make them amenorrheic, that will be the best treatment. How can you make them amenorrheic? You can give GnRH, make them menopause. Or you can remove the uterus and ovary, TAH plus BSO. That will be the best management. Okay? That will be the best management. Right? So, so if you give OCP continuously, continuous OCP, so then you can prevent the shedding off of the endometrium. So that will be the treatment. Okay? So anovulation only, it's not a mode of treatment. So you need to keep the mother amenorrheic. So characteristically regress in pregnancy. Yeah, that's true, because in pregnancy there is no menstruation. So it's true. Non-increase CA125. In endometriosis, CA125 level will increase. True or false?
True, sir. True, sir.
Okay, true. In pregnancy, won't be endometrial cells to be thickened like in the uterine endometrial cells? Yes, of course, endometrium will thicken. But thickening of endometrium during pregnancy, it's not a problem. Thickened endometrium, if it is shed off only, there will be inflammation. That is a problem. Okay, right. So, known to increase the CA125 level, yeah, that's true, Kavinder, because the CA125 will be secreted by the epithelial cell of ovary as well as the peritoneal cell. So whatever the condition which irritate the peritoneum, the CA125 secretion will be high. Even peritonitis, CA125 will be high. Liver disease, CA125 level will be high. Appendicitis, CA125 level will be high. If it is irritating the peritoneum, CA125 level will be high. That's why the CA125 is not a good sensitive test to diagnose the ovarian CA, because which can increase in other condition as well. PID CA125 level will be high. True or false? PID CA125 level will be high. Yeah, that's true. Obviously, it should be, because your peritoneum, the pelvic peritoneum is irritated. So then CA125 level will goes up. So the CA125 level, whatever the condition which lead to inflammation and irritation to the peritoneum, which can increase the CA125 concentration. Right? So that is true. So question number 5, answers are true, false, false, true, true. So now when I'm doing these questions, what I'm doing is I'm just telling the concept. What are the things you need to concentrate when you do the question? So when we do the SB, I will teach you how to approach that question. So that is the very important part. So when we start the theory session, of course, this paper session we are doing for a long time, as we have repeated postponement of your exams, right? So initially we spend much time to revise the theory. So then we have reduced that part. So then later what we did is now we are concentrating how we have to apply the knowledge to the particular question. That is the second part. The final part, most of the students failed in the exam. You don't know how to manage your particular time to do this question. Sometimes you might take more time in the MCQs, and SBA you might spend less time. So then you might not attend all the questions. So there are so many things will play a role, right? In the exam. So probably you might have exam maybe in November mid. So what we have to do is now this is the time for you to prepare within a time period. Right now you have a good background knowledge. You know how to approach the question with the concept. Now the last part, it's going to be how to do the paper in a particular time, right? So coming classes, I will tell you what are the questions you have to touch, what are the questions you should not touch, right? So how many stems you need to mark, how many stems you should not mark. Those things I will teach you in coming sessions. So now this is the time you need to practice how to do the paper in particular time. So for that, what I'm going to do is, as I told you earlier, so coming paper discussions are going to be like the exams, right? So I plan to do the paper in Fridays 12:15 to 4:15. So you will get the paper Thursday evening 7 p.m. Sharp 7 p.m. I will send the paper in the group. The students who are in the group, I will send the paper sharp 7 p.m. I will send the paper to you. Please do the paper honestly. This exam is for you, not for me, right? So don't take the books, right? Don't refer anything. Just do as exam. And time. So why I am doing this is to make you to understand how to manage the time to do this paper within that 2.5 hours. How you are going to do? So you might be wrong. You might get less marks. Doesn't matter. So first paper you might get less marks. Then while we are discussing, then I can have some idea. Okay, these are the questions students did less. What are the mistakes they have done? So I can see the answer sheet, and I can guide you. What are the mistakes? What are the things I need to guide you? So then please, I will send the paper at 7 p.m. on Thursday. By 9:30, you need to finish the paper, and everyone should send the answer sheet at 9:30 to my coordinator. Okay, everyone, I am expecting you to send the answer sheet at 9:30. So when I am telling, okay, stop the paper, please stop the paper and send the answer sheet to us. So we'll try to correct your answer sheet and give it to you. The answers will be, the marks will be sent individually. You don't need to worry whether others will get to know about your marks. You don't need to worry. The answers will be sent individually. So this is actually, this time we are working hard to get a good pass rate. So these are the things, are unnecessary things for me, right? So doing the exam, correcting and sending to you, and after that discussion. So I can do papers and just do a few questions. Then whether you are doing or not, that's up to you. It's not like that. So when we are doing paper, at the end, you have to pass the exam. That is our target. So in a series, I am preparing you for the exam. First, we discuss the theory, then we discuss the concept. Now, the last moment, before the exam, you need to get practice for the time, right? So obviously, these paper, what we are discussing now, you will get most of the same concept in the exam. So if you do this paper repeatedly, definitely you will get. But I will not misguide you. These are the questions will appear in the exam. I will not, even if it is appear, I will not tell, because I don't want that kind of doctors. Okay. So you should know how to apply, apply your concept, how to apply your knowledge, how to manage the time, because those are very important, especially as an obstetrician. When you come to the ward, you might realize it. Within a time, you need to, within a short period, you need to decide and do some intervention to save the mother. So like that. So the time factor is very important. Most of the students have problem with the time factors. So some students might not have, because if they don't know anything, then they can do the paper very quickly and they can finish the paper even within 1.5 hours. They don't want 2.5 hours, isn't it? But students who know something, they will have problem to manage the time, right? So you need to read the question, understand it, then find the correct answer, right? So it might take time. So you need to get practice. So when you come to the Viva class, you will realize it within 5 minutes how to ask all questions, but you need to ask. That is coming with the practice. So for the MCQ also, you need to get practice like that. Within the 2.5 hours, how to do the paper. So please, so don't come to the paper discussion alone, because obviously I know the stuff than you, so I can tell the answer, I can explain you. So don't assess me whether I know the stuff, whether my answers are correct, whether he is teaching well or not. No, don't do that, because I have done all the exam in my life. So until I die, I can work as consultant. I don't have any more exams, but you have so many exams. You need to correct yourself. You need to prepare yourself. Do you understand? So what you have to do is, you have to do the exams. Am I right, lesson then? So you have to do the exams within the particular time. So we will send the paper sharp 7 p.m. Thursday 7 p.m. So some students might attend to my repeat session for the theory. Those students, please let me know. I will give another time for the exam time. But the students who are not attending, doesn't matter. I will send the paper at 7 p.m. 9:30, you're supposed to send the paper to me. Okay? So then, not me, to my coordinator. So then coordinator will correct the paper. You will get the marks. Then you can compare. First paper, I got this marks. Second paper, I got this marks. Third paper, I got this marks. So how, whether, because you have another few weeks to prepare yourself, final preparation. Please don't miss this chance, because if you miss this chance, you don't know when will be the next exam. Isn't it? So then there might be a lot of court cases and we don't know. So then don't miss this chance. Make it clear. Pass the exam this time. Okay? So I'll let you know about the exams, but I'm planning to do the paper like that. It's not going to be the class like this. So of course I will explain the question after that, but first you need to do the exam, then only we will discuss the paper. Then you all can compare your marks, and when we do the last paper, you should be able to pass the exam. Everybody should have that confidence. Yes, I can safely pass the exam if I do like this. So if you have any concern, if you are getting less marks, no worry, please call me. Then I can individually help you, because I can go through your answer sheet. I can assess what is the problem, then I can help you, right? So it will help everyone to get pass. So we can achieve more than 70-80% pass rate this time if you all support me. So I'm happy to spend time other than the class time to help you. So if you get 30 marks, 35 marks, then just call me. Then we can go through your answer sheet and we can find where you did the mistake, what is the mistake, whether it's problem with the theory, whether it's problem with the time factor, whether it's problem with the understanding, whether it's problem with the careless, then we can correct it. Do you understand? Otherwise, until you understand yourself, right? So if I am telling, I'm like Hrithik Roshan, so I should know whether am I like Hrithik Roshan or not. I should know about myself. So if I am saying I am like Hrithik Roshan, I want Aishwarya Rai, then nothing will happen. So then I will die like Abdul Kalam. Isn't it? So first I need to know who am I. So if you know that only, then your expectation will change. Do you understand? So that is the first thing. So realize yourself first. For that you need some assessment. So I will help you. So this kind of things we are doing for the local students. This is how the local students, we are having in-course assessment. They are doing the exams, putting the marks in the notice board. Then only we realize it. Oh, okay, I'm far lower than the pass mark. So then I need to work hard. These are the mistakes I have done. So I'm doing the same thing for you as well. More than that, right? So we will do. So I'll get some other person's help also. So because I need more people to correct individually for you, but I will help you this time. We'll work hard and get through the exam this time. Okay. So we'll start like that. Okay. Question number 6. Regarding the dysfunctional uterine bleeding treatment. Dysfunctional uterine bleeding means there is no function, there is no structural causes. This is a problem with the endometrial function. So that is called dysfunctional uterine bleeding. So the problem is in the endometrial function. The problem is in the endometrial function. That's why it's dysfunction. Dysfunctional uterine bleeding. So if it is a dysfunctional uterine bleeding, right? So then what you want to do, we don't have any measures to assess the function of endometrium. That is the main problem. We don't have any measures to assess the So how to diagnose then dysfunctional uterine bleeding? The dysfunctional uterine bleeding is a diagnostic exclusion. Once you exclude everything, all the causes has been excluded, still patient is having uterine bleeding, abnormal uterine bleeding, then it could be due to dysfunction of the endometrium. Do you understand? This could be due to dysfunction of the endometrium. So in that case, how can you manage? So what you have to do is, one, so the problem is in the endometrial tissue. So then what you can do, you can just simply arrest the bleeding. So how can you arrest the bleeding? By giving the tranexamic acid. That is one. If you make the blood to clot more, then bleeding will arrest. So the tranexamic acid can be a treatment. That is one. Second thing, here problem is in the endometrium. So you can stabilize the endometrium. Once you stabilize the endometrium, or if you make atrophy the endometrium, if the endometrium is atrophied, then the bleeding will be arrested. Do you understand? So how can you make the endometrium atrophy? Give progesterone. So you can give oral progesterone, or you can give local progesterone, whatever, you have to give the progesterone. That is the second option. Third option, where is the problem? Problem is in the endometrium. So you can remove the endometrium. Can you remove the endometrium alone? Yeah. So how do you call that process? That is called endometrial ablation, endometrial resection. So you can resect the endometrium, or you can ablate the endometrium, but only problem if the patient has fertility wishes. If she wants to become pregnant, can you remove the endometrium? No, you can't. So if the patient doesn't have fertility wish, you can do endometrial ablation or resection. Third one, if you want to remove the endometrium, you can remove the uterus. Hysterectomy. That is the last option. Once you remove the uterus, will they have bleeding? No. So these are the management. So these are the principle, nothing else. Because the problem is in the endometrium. So you need to do something for the endometrium. Okay, now we'll come to the answer. So dysfunctional uterine bleeding management, NSAID is the first line treatment. What do you think? NSAID is first line treatment. Obviously it's false, right? Because the NSAID we are giving for the pain. Because when you give the NSAID, the bleeding loss is 25%. For the 25% blood loss reduction, we don't give the NSAID. So NSAID is recommended for the dysmenorrhea, not for the menorrhagia. If somebody has menorrhagia and dysmenorrhea, then you can combine the mefenamic acid with tranexamic acid. So because NSAID has a lot of side effects, like peptic ulcer disease, right? So there are a lot of side effects. So the risk benefit, the risk is more when you give NSAID for the bleeding loss only. If it is a pain, then pain management, the NSAID will be the best option. So NSAID we don't give for the dysfunctional uterine bleeding. That is false. Tranexamic acid give at luteal phase. True or false? Tranexamic acid give at luteal phase. Yes. Actually, the tranexamic acid, what is tranexamic acid? Yeah, Tisura, it's correct. So what is tranexamic acid? Tranexamic acid is an antifibrinolytic agent. So it means the tranexamic acid will maintain the blood clot. So tranexamic acid will be useful only when somebody form blood clot. So the tranexamic acid only you can use when somebody bleeding. If they are not bleeding, if you give tranexamic acid, no use. Do you understand what I'm telling? Because if somebody is bleeding only, that time clot formation will be formed, then tranexamic acid will stabilize the clot. If it is no clot formation, no bleeding, is it used? No. During the luteal phase, there is no bleeding. During the menstrual phase, when you see the menstrual cycle, there are three phases: proliferative phase, luteal phase or secretory phase, and menstrual phase. So proliferative phase, endometrium is proliferating. That time there is no bleeding, no place for the tranexamic acid. In the luteal phase, endometrium is secreting, no bleeding, so no place for the tranexamic acid. During the menstrual phase, endometrium shed off and patient is bleeding. You need to arrest the bleeding. So then you have to give tranexamic acid. So tranexamic acid can be given during the menstrual period, not during the follicular or luteal phase. So how we are giving the tranexamic acid? We are giving the tranexamic acid 500 milligram 3 times during the bleeding time. So we are advising the patient, when you start bleeding, take this tablet. The first day when you start bleeding, take this tablet. That is how we are advising the patient. Do you understand what I'm telling? We don't give when the patient is not bleeding. So the tranexamic acid given at luteal phase, that's false. No, not luteal phase. We are giving at bleeding phase. So is there any embolism if we give tranexamic acid mistakenly to the patient who are no active bleeding? No, there is no risk of embolism. That's false. COCP is effective. What do you think? For the dysfunctional uterine bleeding, COCP is effective. So obviously effective because COCP will stabilize the endometrial tissue. Your progesterone is there, so that will stabilize the endometrial tissue. So COCP is one of the treatment modality for the dysfunctional uterine bleeding. That's true. Endometrial ablation useful in infertile couple. Endometrial ablation is a useful method, but not for the infertile couple. If you ablate the endometrium, then she can't become pregnant. So that is not possible or not recommended for the infertile couple. Do you understand? Right. Intrauterine progestin device to reduce the chance of hysterectomy. Yeah, that's true, no? Intrauterine progestin device. So that is your local progestin. Once you insert the local progestin device, that progestin will diffuse into the endometrial tissue, and endometrial tissue will become stabilized and atrophied. So then bleeding will reduce. So then it will reduce the chance of hysterectomy. Or otherwise, to manage this patient, we need to do the hysterectomy. So the intrauterine progestin device to reduce the chance of hysterectomy, that is true. So the answers are false, false, true, false, true. Right. Question number 7, causes of premature menopause. Combined oral contraceptive pills. So if you use the combined oral contraceptive pills, that will not affect your age of the menopause. That is false. Endometriosis, again we discussed earlier, that will not affect your age of menopause. Pelvic infection, what do you think? That is true, because when you have the infection into the ovary, oophorytis, TB oophorytis, when you have the infection into the ovary, that infection might damage the follicles and follicular number will reduce. So then the follicles will deplete bit early. So any kind of infection in the ovary can cause pelvic early menopause. That is true. Chemotherapy, what do you think? Yeah, that's true, because chemotherapy will destroy the follicle, number of follicle will come down. So then premature ovarian failure risk is high. Radiotherapy, yeah, that's true, right? So cystectomy, repeated ovarian cystectomy, true or false? Repeated, yeah, obviously true, because you are cutting the ovarian cortex and removing the follicles, the follicular depletion, which can cause premature ovarian failure. Autoimmune disease, yeah, because autoimmune disease can destroy the follicle, right? So that might damage the follicular count and reduce the follicular count, which can cause premature ovarian failure. So the answers for question number 7, false, false, true, true, true. Urodynamic stress incontinence. So regarding urodynamic stress incontinence, of course, I have done several classes regarding this urodynamic stress incontinence. So what is urodynamic stress incontinence? When the patient is coughing, the urine is leaking, right? So this is your bladder, this is the bladder neck, right? This is the urethra, right? Bladder neck and urethra, and the urine is coming out like this. So when compared to male urethra and female female urethra doesn't have a well-developed extrinsic sphincter. Well-developed extrinsic sphincter. But in female urethra, male urethra, you are having a well-developed extrinsic sphincter. So as we don't have extrinsic sphincter, the support to the bladder neck is given by the pelvic diaphragm, levator muscles, pelvic diaphragm. That is the muscle which giving the support to the urethra. So urethral, so pelvic bladder neck, right? So due to some reason, maybe due to aging, your muscle power will reduce, then your support will relax. Due to damage to the muscles, like in vaginal delivery, damage, denervation, devascularization, causing muscular weakness here. So any kind of weakness, what will happen? This urethra and the bladder will come down bit like this. So now the bladder neck is somewhere here, lower down. Due to descent of this bladder neck, you will not get this support from the pelvic floor. So then if the intra-abdominal pressure increase, the urine start to leak. Urine start to leak. So descent of this bladder below the pelvic diaphragm, which can be a cause for urinary stress incontinence. So then what is the management? Nothing. You need to stabilize the pelvic floor, strengthen the pelvic floor. For that, you need to do the exercise that is called pelvic floor muscle exercise. Second one, you need to replace the bladder to the normal position. So then surgery is the mainstay of treatment for this stress urinary incontinence. So there are several surgeries. One is Kelly stitch. Second one is Birch-Kolpo suspension. Third one is the tape procedures, right? So we will discuss those things in another question. So there are so many surgical methods we can use to treat this condition. So here the question is regarding urodynamic stress incontinence occur due to descent of the neck of the bladder. What do you think? Urodynamic stress incontinence occur due to descent of the neck of the bladder. That is the one now we discuss, right? When the neck of the bladder descent down, the support will be lost. So then they start to leak. That's true. Birch-Kolpo suspension is the treatment of choice. Yeah, now I told you. So you need to do the surgery. So in Birch-Kolpo suspension, what we do is we are suspending the bladder here and pull it and anchor to the pelvic bone, the pubic bone. So you are pulling up and anchor to the pubic bone. So then what will happen? It will not descend. So you are replacing to the normal position. That is your Birch-Kolpo suspension. So always the stress urinary incontinence need surgical management than the medical management. Medical management is because if you take any tablet, will it pull the bladder up? Can you have any tablet like that to pull the organ up? No. So you need to surgically correct the descent. So then you have to do the surgery. Birch-Kolpo suspension is the treatment choice. That's true. Become common with increasing age. What do you think? Obviously, right? No, it's not like that. Right? Become common with the increasing age. Yeah, that's true, because with increasing age, the power and the strength of the muscle will lose. So then, yeah, ligaments are become lax, right? Yeah, Sanjeevan. So then it is a risk factor for descending. So somebody asked, it says the treatment means there is no other treatment. It's not like that, right? So birth colpo suspension is the treatment of choice. It means the best treatment among the other methods. The birch is the best treatment. That's true. More incidence in nulliparity than multiparity. What do you think? That obviously false, because when you have vaginal delivery, the ligamental damage, muscular damage is high. So the descent risk is high. So multiparity is more risk than the nulliparity. That is false. Can be effectively treated by anticholinergic. That's false, right? So that is common for that is for the urge incontinence. For the stress incontinence, effectively you have to treat by the surgery, not for the medical. So that's false. So the answer for question number 8, true, false, false. Right. Question number 9, post-operative care of morbidly obese woman. Morbidly obese woman. It means BMI more than 35. Right? So morbidly obese means BMI more than 35. It's overweight more than 25, obese more than 30, morbidly obese more than 35. It's morbidly obese woman in post-operative care after hysterectomy. What are the problems? What are the complications we are anticipating? The major complication we are anticipating is deep vein thrombosis. And deep vein thrombosis. Second one is wound healing might affect, right? Because of the obesity and sweating, wound healing, the risk of infection, right? So how can you overcome these problems? One, if you are suspecting deep vein thrombosis, you need to do some intervention to prevent the deep vein thrombosis. What are the intervention? Bandage, stockings. You can put the stocking to press the venous system. So then there won't be any collection of blood into the venous system and it will pump up, then clot formation will be less. So the usage of stocking. You need to dilute the blood. You have to prevent the hemoconcentration. So how can you dilute the blood? Ask the patient to take more fluid, increase oral intake. That is second. Third one, early mobilization, right? Early mobilization. You need to ask the patient to mobilize very early. Fourth one, you have to give some prophylactic treatment for the DVT. What is that? That is your lower molecular weight heparin, enoxaparin. Right? So those are the things we are giving to prevent the DVT. Right? So then there is a risk of infection. Then what do you have to do? You have to give the prophylactic antibiotic even in the absence of infection. Good glycemic control. Right? So now they are asking post-operative care of morbidly obese woman following abdominal hysterectomy, graduated pressure stocking, of course we need to give. Low molecular weight heparin, yes, we need to give. Antibiotic treatment for 24 hours to reduce the infection, yes, we need to give. Steroid therapy to reduce the inflammation, that is false. You should not give steroids to reduce the inflammation, that's false. Delay the mobilization to promote the wound healing. Obviously false, no? Then it is a risk factor for the DVT. You should not do that. Early mobilization, right? So this is the concept now. If it is obese, they are asking what are the complications you are anticipating, how to prevent it. So basically, if you see each and every question, what they are expecting from you, if you are a house officer, right? If you are a house officer, what are the things you are going to do for a patient with post-surgical care with obesity? Right? Okay, so antibiotic should be more than 24 hours. Not really. Actually, if it is a clean surgery, you don't need to give the antibiotic. That is the recommendation, guideline recommendation. As it is obese, we need to give additional antibiotic. That's why we take it as 24 hours true, right? And why we don't give the steroids? Steroids will inhibit the inflammatory process. So then immunosuppression is a risk factor for infection. So if a patient has Risk for the infection, is it useful to give, or is it safe to give steroids? No, it's not safe. So that's why we take it as false. So answer for question number 9, true, 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 false, false. Right. So question number 10, risk factor for DVT in obstetrics and gynecology. Risk factor for DVT in obstetrics and gynecology, breastfeeding. Breastfeeding is not a risk factor for the DVT. That's false. Feeding, it's not a risk factor for DVT. Right? Breastfeeding is not a risk factor. Antiphospholipid syndrome, obviously APLS is a risk factor for DVT. It's a high risk for the DVT. That's why we are giving low molecular weight heparin in the postpartum period as well, right? So that is true. Obesity, again we discussed, obesity is a risk factor for the DVT. Cesarean section, what do you think? Any kind of pelvic surgery, especially in pregnancy, is a risk factor for DVT, right? Pelvic surgery, estrogen are risk factor for DVT. That's why if a woman in OCP, you need to stop the OCP 4 weeks prior to the surgery to prevent the DVT. Because OCP is a risk factor for DVT, pelvic surgery is a risk factor for DVT. While on OCP, if you do pelvic surgery like hysterectomy, risk of DVT will be high. That's why they recommend OCP should be omitted prior to 4 weeks prior to the delivery. Sorry, surgery. Okay, right. So cesarean section is a risk factor. Among the cesarean section, emergency cesarean section is more risk than the elective cesarean section. So there is a scoring system. I didn't tell you because it's too much for you. If it is elective cesarean section, score is 1. Emergency cesarean section, score is 2. It means emergency cesarean section has higher risk than the elective cesarean section. Okay, right. Pelvic malignancies. Yeah, all the pelvic malignancies, especially the ovarian risk for the high risk for DVT. Right. So hopefully the corona will not spread through the Zoom, right? Will it? No. Okay. Right. So the answer for question number 10, false, true, 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 true. Right. Question number 11 regarding PPROM. So what is PPR? What is PPROM? Preterm, pre-labor rupture of membrane. Right? Preterm, pre-labor rupture of membrane. So there are two things. One, preterm. It means the membrane got ruptured prior to 37 weeks. That is the first thing. Second, pre-labor. It means patient not in labor. Right? She doesn't have uterine contraction. So preterm, pre-labor rupture of membrane. So if somebody has membrane rupture without pain at 38 weeks, that is called PROM, pre-labor rupture of membrane, not a preterm. So if it is a PROM, we have only one problem. What is the problem? Once the membrane got ruptured, the infection can ascend and cause chorioamnitis. Right? That is the problem. So if you want to prevent this complication, what you can do, you can deliver the baby. Because baby is eligible to deliver. Because baby is 38 weeks term. So you can deliver. So only problem is infection. But in case of PPROM, you have two problems. One, the membrane got ruptured. So the risk of infection, all kind of things are there. That is one. Second, this is preterm. Baby is not ready to come out also. If you deliver the baby, then baby will have some kind of complication due to preterm, prematurity. So now you need to decide, are you going to deliver the baby or are you going to keep? Both are danger. Even if you deliver, baby will have preterm related complication like respiratory distress, necrotizing enterocolitis, infection, NICU admission and things like that. But if you keep this baby, as membrane got ruptured, there is a risk of infection, chorioamnitis, fetal distress, cord prolapse, and fetal death, and maternal sepsis and maternal death. So both are danger. Now you need to assess which one is more danger, delivering or keeping. If no fetal distress, no features of infection, no maternal compromisation, will you deliver or will you wait? Wait. If something happened, baby is in danger or mother is in danger, then deliver. So your management is simple. You monitor the complication. If no complication, prolong the pregnancy until the term. If complication, deliver the baby a bit early. While you are prolonging, you can do some intervention to prevent the complications. What are the complications you are anticipating? Respiratory distress. If you are anticipating respiratory distress, can you prevent the respiratory distress? Yes. You can give dexamethasone. You are anticipating infection. Can you prevent the infection? Yes. How? You can give antibiotic prophylaxis. Do you understand? So this is the principle. Don't memorize anything. This is the principle. Now we'll read the question and we utilize this principle to this question. Regarding PPROM, bacterial vaginosis is a cause. Why the membrane got ruptured? Because membrane lost the stabilization. There is an inflammation and membrane integrity has lost and ruptured. So why there is an inflammation? There might be infection. So any condition which lead inflammation into the cervix and the membrane, which can cause rupture of membrane. So this could be due to infection, this could be due to surgery, this could be due to trauma, this could be due to any kind of irritation here, which can cause rupture of membrane, which can cause labor. So bacterial vaginosis is an infection. That infection can cause irritation and rupture of membrane. Yeah, the bacterial vaginosis can be a cause. That's true. Recur in next pregnancy. What do you think? Rupture of membrane, PPROM, recur in next pregnancy. That's depend on the cause. If it is due to Trichomonas vaginalis, which can recur, right? You can't say PPROM will not recur. If somebody has PPROM, next time they are having high risk to have a PPROM, because if it is due to infection, that infection can recur. So which can recur? That's true. Yeah, which can recur. That's true. Associated with fetal anomaly. What do you think? True or false? It's true. If it is a anencephaly, then it might associated with polyhydramniosis. When the membrane got stretched more and more, then it might get ruptured. So it might associate with fetal anomaly. That is possible. The anomalous baby has high risk to have a PPROM. That's true. In the absence of infection, antibiotic should be prescribed. What do you think? Yeah, that's true. That's what we discussed. We are giving antibiotic for prophylactic purpose. What is prophylactic purpose? Prevention. Prevention of chorioamnitis. Of course, there is no infection, but we are giving the antibiotic to prevent the infection. Prophylaxis. So in the absence of infection, we are giving. That's true. Right? So in the absence of infection, antibiotic should be prescribed. True. Bishop score must be determined. What do you think? In PPROM, Bishop score must be determined. False. You should not put your finger into the vagina to the PPROM. Why? Because membrane got ruptured. She's not in labor. If you put your finger into the cervical canal to assess the cervical length and Bishop score, you are inoculating the organism into the uterine cavity. That is a high risk of chorioamnitis. If the patient develops pain, if the patient has symptoms of labor only, you need to do the PE. If it is a PPROM, no labor. What is the purpose of doing V? She's not in labor. You are planning to prolong the pregnancy. What is the purpose of doing V? Why you are doing the V? To assess the labor status. Is she on labor? No. She's not on labor. Are you going to deliver the baby now? No. Then why are you putting the finger into the vagina? That should not. If the patient is not in labor, you should not do the V. Do you understand? So don't memorize. Don't memorize. V is contraindicated for PPROM. You can think, why I am doing V? Do I want to do the V? No, no need. So the Bishop score must be determined in PPROM. Do you want to assess the Bishop score for a patient without labor? No. So then it's false. So answer for question number 11, 2, false. Question number 12, pre-pregnancy counseling include stopping antimalarial prophylaxis. That's false. You don't need to stop the antimalarial prophylaxis because quinolone can be given as a prophylaxis during the pregnancy as well. So you don't need to stop. That's false. Stopping antithyroid drugs, again, it's false. You should not stop the antithyroid drugs, right? So you can continue the propyl thiouracil rather than the carbimazole. Carbimazole and propyl thiouracil, two drugs we are using, but carbimazole has slightly increased teratogenic effect than the propyl thiouracil. That's why the recommendation is in first trimester we have to use the propyl thiouracil. After first trimester you can use carbimazole or propyl thiouracil, right? So you should not stop the antithyroid drug. You have to continue. But if the patient is on carbimazole, you can change to propyl thiouracil during the pre-pregnancy as well as the first trimester. That is false. Stop smoking, obviously. If somebody want to have baby, then they have to stop smoking because that is not good for the mother or baby, right? That's true. Oral hypoglycemic should be changed to insulin. That's false. Not the all oral hypoglycemic. If the patient is on contraindicated or teratogenic oral hypoglycemic, you need to change to the non-contraindicated one. Say, for example, if the patient is on glipizide, glibenclamide, so not glibenclamide, gliclazide, acarbose, topramide, so then you can't use that drugs. You need to change to insulin or maybe metformin. You can use metformin and gliclazide, glibenclamide during the pregnancy. Metformin and glibenclamide, those are the two oral hypoglycemic agent we can use during pregnancy. So all the you don't need to stop all the oral anti-hypoglycemic agent, right? So that is wrong, right? So folic acid should be stopped after diagnostic pregnancy. That's false, right? So if you give the folic acid until postpartum period, you need to give the folic acid. So that's false. So the answers are false, false, true, false, false. Features of reactive CTG: baseline heart rate 120. That's true because the normal baseline heart rate should be in between 110 to 160. If the baseline heart rate is 120, that is normal. That is true. Presence of 2 acceleration in 10 minutes. Ideally, there should be 3 acceleration in 10 minutes. It is a reactive trace. But so if you have acceleration 2 within 30 minutes, you can't say it's not a reactive. So we have to take it as reactive. That's true. Early deceleration, any kind of deceleration, whether it's early, late, variable, prolonged, whatever the deceleration, the decelerations are always abnormal. So you can't take it as reactive. Even though the early deceleration is not harm to the baby, decelerations are not reactive features, right? So you can't say it's reactive. So that's false. Baseline variability 4 beats. So the variability is changing of the baseline. So usually the baseline changing should be more than 5, should be less than 25. The variability should be in between 5 to 25. 5 to 25. If it is less than 5, that is called reduced variability. More than 25, that is called saltatory pattern. So both are abnormal. So if it is less than 5, that is reduced variability. So here they mention baseline variability 4 beats. That is reduced variability. So that is false. Presence of uterine contraction. If somebody have uterine contraction, that is reactive CTG. Sanjeev? To comment about reactive CTG, we don't consider the uterine contraction. The reason is you will get the contraction only during the labor. If you do the CTG in the antenatal period, patient without labor, will you have contraction? No. So then you can't comment about the contraction. So the contraction will not taken as reactive or not. Contraction not play a role in the reactive CTG. So in reactive CTG, we are seeing 4 factors. One, the baseline should be in between 110 to 160. Variability should be in between 5 to 25. There should be acceleration. There should not be any deceleration. Those are the 4 features to tell whether it's reactive or not. Right? There is no place for the contraction here. Right. So answer for 13, true, true, false, false, false. Question number 14 regarding oxytocin. Best used as bolus for the induction of labor in primary mother. So we never use as the bolus. We are using as infusion. So the bolus means you are giving us a bolus dose. When we are giving oxytocin as a bolus after delivery of the baby to make the uterus to contract in active 3rd stage of labor, we are giving bolus. For the induction of labor, we are giving oxytocin as infusion. So this is the reason always I am telling you need to read the question carefully and slowly and mark it. So because most of the students, they know the answer, but they mark it as false. True. Best used as a bolus because everybody knows oxytocin will be used for the induction and they put it as true. But they mention as bolus. That is the word is important here. So please, when you do the question, read the question carefully. Each and every word is important. Right? So we are giving as infusion, not as a bolus. Bolus for the active 3rd stage management, infusion for the induction of labor. You can't give higher amount of oxytocin suddenly, then it will cause sudden contraction and fetal death and the uterine rupture risk is high. So we don't give the bolus for the induction. That's false. Hyperstimulation of the uterus is a known complication. Of course, that's true. When you give the oxytocin, uterus will contract more and more. That might lead fetal distress. So once the fetal distress and more contraction, more than 5 contraction in 10 minutes, that is called hyperstimulation. Right? So that's true. So shouldn't be used with large infusion volume. That's false because how we are giving the infusion for the multi 2 unit in 1 pint normal saline, primary 5 or 4 unit in 1 pint normal saline. After putting into the large amount of saline, then we are giving as a slow infusion, 15 drop, right? 15 drop, 30 drops, 45 drops, 60 drops. So we are giving with a large volume of normal saline, not as a bolus, right? So for the multi 2 unit in 1 pint normal saline, for the primary 4 units or 5 units in 1 pint normal saline, right? So shouldn't be used with a large infusion volume. That is false. We are giving with a 500 only 2 units like that. Contraindicated in twin mother. Oxytocin is contraindicated in twin mother. That's false. You can use. It's not false. It's not contraindicated. You can use induction of labor with for the twin as well. False. Effective in management of atonic PPH. Atonic PPH. Atonic means uterus is not contracting. You want to make the uterus to contract. So then you have to give the uterotonic drug. That is your oxytocin. So it's effective. That's true. So answer for 14 is false, true, false, false, true. Right. Question number 15, causes of unstable lie. What do you understand by unstable lie? What is lie? Lie is relationship between the longitudinal axis of the baby and longitudinal axis of the uterus. So the uterus is like this, baby is like this, both are in a longitudinal axis. So then it's called longitudinal lie. So if the baby is in transverse to the uterus, then that is transverse lie. This is oblique lie, right? So that is lie. Sometime baby will not be in a stable lie. Baby will not be as a longitudinal lie all the time. So today is longitudinal lie, tomorrow is oblique, day after tomorrow is transverse, then again longitudinal, then again it's changing the life. Why it's not why it's changing? Because the space, it's not adequate to be in a normal position. Something is occluding in the lower part, which can cause turning of the baby, right? So those are the causes for unstable life. So they ask, so causes for unstable life, oligohydramnios. What do you think? Oligohydramnios can cause unstable life. So please, before you answer the question, take a deep breath, concentrate on the question and answer it. Oligohydramnios can be a cause for the unstable life. So if it is oligohydramnios, lico is less. So can baby turn easily? No. So the baby will not turn easily. If the baby is not turning easily, is it easy for the unstable life? No. So life will not change frequently because baby will not turn easily. But if it is a polyhydramniosis, baby is floating, then baby will turn his position time to time. So oligohydramnios is not a risk factor for the unstable life. Polyhydramnios is the risk factor for unstable life. Oligohydramnios is a risk factor for breech presentation. True or false? Oligohydramnios is a risk factor for breech presentation. True or false? That's true. Why? Because if the baby got arrest in breech, then it will not turn spontaneously. It will arrest as a breech. That's the reason the oligohydramnios is a risk factor for the breech presentation. Do you understand? Right, fine. So oligohydramniosis, it's false. Uterine septa, what do you think? Uterine septum is a risk factor for unstable life. Yes? These are very nice questions, really. You will get this question in the exam. Yeah, of course, because if it is a uterine septum, the space is not adequate, then baby will turn the position time to time. That's true. Submucosal fibroid, again, same. Any fibroid inside the cavity will turn the baby time to time. That's true. Endometriosis, there is nothing, no, in endometriosis is something outside. The problem is outside, endometrial tissue present outside, not the problem in the cavity. So that's false. Placenta previa, yeah, that's true, because the placenta is occluding the lower part, then baby will turn. So answer for question number 15, false, true, true, false, true. Right. Question number 16. Anti-D immunoglobulin is not indicated in Rh negative mother. So ROGAM is not indicated in Rh negative mother. Prophylactic anti-D immunoglobulin have been given during the antenatal period. So if somebody received prophylactic anti-D, that is called routine antenatal anti-D prophylaxis. Why we are giving this routine antenatal prophylaxis is to prevent the silent feto-maternal hemorrhage. That is a different issue. But during the delivery, there will be an additional feto-maternal hemorrhage. To neutralize that blood, you need to give the prophylaxis. So your routine prophylaxis and the sensitizing event prophylaxis is totally different. Whether you are giving routine or not, you need to give each and every sensitizing event. Okay, so prophylactic anti-D given during the antenatal prophylaxis, you need to give. So the statement is false. The baby is stillborn, baby died, death baby. Do you want to give the prophylaxis or not? You want to give. So here, not indicated, so it's false, it's indicated. Direct Coombs test in the cord blood is positive. Do you want to give or not? If the Coombs test is positive in fetal blood, will you give the ROGAM or not? Okay, answer my question. What is the meaning of direct Coombs test positive? What is the meaning of direct Coombs test positive? Yeah, very good. If the direct Coombs test is positive, it means already mother sensitized antibody already formed. That antibody crossed the placenta and the baby has antigen antibody complex. It means mother already sensitized. If direct Coombs test is positive, means mother already sensitized. If the mother already sensitized, why we are giving the Rogam? For the prevention of sensitization. So she already sensitized. So is it worth to give the Rogam now? No, because already she sensitized. For the sensitized mother, no point in giving Rogam. If the mother is not sensitized, yes. So that's why we do Coombs test. If Coombs test is negative, you need to give the Rogam. If Coombs test is direct Coombs test is positive, no point in giving Rogam. So the direct Coombs test positive in the cord blood is not indicated. True or false? It's true because you don't need to give. Right, good. 48 hours after lapsed from the childbirth. If the baby delivered 48 hours ago, is it not recommended or recommended? Is it worth or not? It's worth. Up to 72 hours you can give. It's recommended. So still you have to give. Yeah, still you have to give. So that's false. Sensitization was performed at cesarean section. Sorry. Sterilization was performed at cesarean section. If you do LRT, you don't need to give the Rogam. What do you think? No, it's false. You need to give because sometime patient might have failed LRT. Patient might need reversal of LRT. So don't let the patient to sensitize. That is not good. So still you need to give. That's false. So answer for question number 16, false, false, true, false, false. Right. Question number 17, GDM. GDM can exclude by normal GTT at 14 weeks of POA. You are doing the OGTT at 14 weeks. You can exclude whether it's GDM or chronic diabetes. OGTT abnormal. So then what do you say? It's OGTT or the GDM or chronic diabetes. What is the definition of GDM? The newer definition of GDM? The first recognition of glucose intolerance during pregnancy. The earlier definition, there were cut off like 20 weeks. Now we don't talk about this 20 weeks talk. If you recognize the abnormal OGTT first time, that is the definition of GDM. But you can't confirm the GDM without knowing the POA. Say for example, if the patient has normal OGTT at 12 weeks and abnormal OGTT at 20 weeks, then you can say this is GDM. Okay? Normal OGTT at 12 weeks, abnormal OGTT at 20 weeks, you can completely say, yeah, this is GDM. Now, OGTT abnormal at 16 week, it could be GDM or it could be chronic diabetes. We don't know. We are confusing. So then what we do is we are diagnosing as diabetes in pregnancy, hyperglycemia in pregnancy, HIP. But the confirmation will be done in a retrospective way. What is retrospective way? We are waiting until 6 weeks of postpartum period. So by 6 weeks, your placental hormones will be removed from the maternal blood. So there won't be any effect due to pregnancy by 6 weeks. In postpartum 6 weeks, when you do the OGTT, if the OGTT is normal, what is the meaning of that? This glucose intolerance due to placental hormone. So this is GDM. After 6 weeks, still OGTT is high, then this is not due to placental hormone. This is chronic diabetes. Do you understand? So the confirmation will be done by retrospective way. So you can't simply exclude by OGTT at 16 weeks. Do you understand? So they mentioned can exclude by normal OGTT at 14 weeks. No. You can't exclude. Still there is a possibility, then you need to exclude by the retrospective manner. That's false. Increase the risk of congenital abnormality. GDM increase the risk of congenital abnormality. That's false, obviously, because if it is a confirmed GDM, that will be after 20 weeks. So the organogenesis will be occur in first 12 weeks. So initial 12 weeks, your blood sugar is normal, so there is no risk of congenital abnormality. If it is a chronic diabetes, from the beginning, patient will have abnormal blood sugar, so which can cause you congenital anomaly. So the risk of congenital anomaly will not be there for GDM. Congenital anomaly will be the consequence of chronic diabetes, not the gestational diabetes. Okay, right. Increased risk of developing diabetes in later life. GDM has increased risk of diabetes in later life. Yes, that's true. Around 50% of mothers will develop diabetes in 5 years' time. Among the gestational diabetes mothers, around 50% of mothers will develop diabetes in 5 years of time. Do you understand? Right. So that is true. Women with PCOD has increased risk. PCOD has increased risk. What do you think? Yeah, that's true, no? Because in polycystic ovarian syndrome, they will have insulin resistance. They will have insulin resistance. So insulin resistance is a risk factor for the PCOS. That's true. Metformin is the drug of choice in controlling glycemia. GDM, metformin is the drug of choice. Actually, this is a past paper question. So that's why I didn't want to change the stem. Better to leave this stem without answering. You know why? Because, so I have read 2-3 guidelines for this question, and I asked from someone also. The metformin is the drug of choice. There is no recommendation like that. Which one is good, metformin or insulin, right? So some guidelines say metformin is best. You can use metformin. Some say insulin is best, but mostly we are using insulin. But we don't have evidence to recommend this is the best one. But commonly we are using insulin rather than the metformin. But they have mentioned metformin is the drug of choice. We can't say it's a drug of choice, right? So insulin is the best one, but there is no evidence to say this is the best one. But most unit, they are practicing insulin commonly for the GDM. Do you understand? Right? So that's why, so we have to take it as false, or otherwise leave this stem without marking, right? So answer false, false, true, true, and fifth one, it's questionable, right? Question number 18, regarding the induction of labor, increase the risk of cesarean delivery. Yeah, that's true, because failed induction will increase the risk of cesarean section. That's true. It's less likely to fail if modified Bishop score is 3. That's false. If the Bishop score is more than 7 only, the success rate will be high. If it is less than 7, it's unfavorable cervix. So induction failure rate will be high. That's false. By artificial separation of membrane is ineffective. That is false. Because artificial separation of membrane is an effective method of induction of labor. It will reduce the formal induction also. So it's an effective method. You can't say it's ineffective. That is false. More successful in multigravida than primigravida. There is no talk like that. Whether the induction of labor is more successful in multipara or primi, there is no evidence saying which one has high success rate. That's false. Increased risk of postpartum hemorrhage. Yes, that is one of the complication of induction of labor. Induction of labor has high risk of PPH. Not only high risk, also the induction of labor will need high demand for the pain relief than the spontaneous. That is also MCQ point. Do you understand what I'm telling? So if somebody having spontaneous onset of labor, I'm having spontaneous, Lasanda has induction. Who need more pain relief? I need more pain relief, because patient who enter the labor with the induction need more pain relief than spontaneous one. Do you understand? So these are research evidence and you should know that. So it has risk of PPH, it has risk of cesarean section, it has risk of uh, uh, demand for the pain relief, right? Okay, that's fine. So answer for question number 18, true, false, 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 true. Question number 19, shoulder dystocia is managed by placing the woman in macrobot position. There is no question. That is the first step. Macrobot position and suprapubic pressure. Fundal pressure, what do you think? You should not do the fundal pressure. If you give the fundal pressure, the scenario will get worse, right? You should not give the fundal pressure. You have to give the suprapubic pressure, right? Wide episiotomy. Actually, the shoulder dystocia management can be first line management, second line management, and third line management. The first line managements are suprapubic pressure as well as the macrobot position. For suprapubic pressure and macrobot position, you don't need to extend the episiotomy. You don't need to extend the episiotomy. The reason is the obstruction is actually behind the pubic symphysis, not in the perineum. So no point in cutting the perineum to make the perineal opening larger. So you just deliver the baby because already head came. So that is the most difficult part. Through the perineum, head came out. So then no need of episiotomy now. But if the first line treatment fail, second line treatment, you are going to do the internal maneuver. You are going to put your finger inside the perineum and do some maneuver. So in addition to the baby set, you are going to put your hands in. So now you need more space. For the second line maneuver, wood screw maneuver, reverse wood screw maneuver, right? And posterior arm delivery, right? So Rubin's maneuver, whatever. For your internal maneuver, you are going to put your hands in, then you need more space, right? You need more space. For that, you need to make the introitus larger. So for that, you need to do the episiotomy. So anyhow, the question is, shoulder dystocia is managed by wide episiotomy. Yeah, that's true. Wood screw method, what do you think? True or false? Are we using the wood screw method? Yeah. Robin's maneuver, wood screw maneuver, reverse wood screw maneuver, those are recommended. That's true. Loveset maneuver. True or false? Loveset maneuver. Where we are using the Loveset maneuver? It's false. The Loveset maneuver we are using to deliver the extended arm in breech delivery. Right? So we are using the Loveset maneuver to deliver the extended arm in wood screw maneuver. That's false. So answer for question number 19, true, false, true, true, false. Question number 20, IUGR due to uteroplacental insufficiency. So the IUGR can be two types. One, the late onset of IUGR and early IUGR. So the early IUGR, we are having the insult at the beginning. The late IUGR, the insult in later part. So mainly the late onset of IUGR is due to uteroplacental insufficiency. Right? So if it is an early onset of IUGR, usually the entire fetal growth will affect. So the baby entirely will get affected. But in late onset of IUGR, especially in uteroplacental insufficiency, the initial part of the fetal growth was normal. Later, the growth has been reduced. Right? So in that case, the fetal head will be normal in size, but the abdominal circumference will reduce. The reason is the glycogen storage in the liver and fat storage in the abdominal subcutaneous tissue will reduce. So the abdominal girth will reduce. So that is the same thing. When you are fasting, when you are doing exercise, what you are checking your tummy, whether it's reduced or not. Isn't it? If you do exercise, if you do gym workout, will your head circumference reduce? No. Will not. That will be same, but yeah, it's a V shape. Your abdomen will become smaller, right? So then only you will get six pack and things. So the same thing will happen in the baby also. When the baby has some kind of insufficiency in the later POA, the abdominal circumference will reduce, the head circumference will retain the same. So then there will be asymmetry between the head circumference and the abdominal circumference. Right? So now the question is regarding IUGR due to uteroplacental insufficiency. Fetals fail to achieve the growth potential. That is the definition of IUGR. Fail to achieve the growth potential, right? So you are supposed to get 80 marks, but you are getting 45 marks. So that is IUGR. You are not reaching your potential, full potential, right? You are not reaching the full potential. So that's true. Oligohydramnios is the feature. Oligohydramnios is the feature. What do you think? Yeah, that's true, because if the placental blood flow reduce, the fetal kidney blood flow will reduce, fetal kidney urine formation will reduce, ultimately baby will develop oligohydramnios. Give me 1 minute. Right, okay. So oligohydramnios is a feature. Yeah, that's true, right? And use of prostaglandin for cervical ripening is absolutely contraindicated. What do you think? Use of PG for the cervical ripening is absolutely contraindicated. What do you think? It's false, right? The problem is when you use the prostaglandin for the induction, when the uterus is contracting, the uterine blood flow might get affected and baby might have hypoxia. That is our worries. But that is not a contraindication. Okay? That is not contraindicated. So uterine PG is not contraindicated for the IUGR. You can use, but it's caution. When you give, there is a risk of fetal distress. Low threshold for cesarean section. So it's not contraindicated. That's false. Long-standing DM is a cause factor. Yeah. What do you think? Yes, because the long-standing diabetes can cause vasculopathy, which can cause formation, affection in the formation of blood flow or the placental vessels. So chronic diabetes, chronic hypertension, chronic diseases, all kind of chronic diseases can cause IUGR. But if it is a GDM, it's a risk factor for macrosomia, not the IUGR. Chronic diabetes is a risk factor for IUGR. GDM is a risk factor for macrosomia. So that's true. Typically produce asymmetrical growth restriction. Uteroplacental insufficiency typically cause asymmetrical growth restriction. That's what we discussed. So if it is a uteroplacental insufficiency, it's usually late. So then patient will have asymmetrical pattern than the symmetrical pattern. So that's true. So answer for question number 20, 2, false, 2, true. So I think it's a good balanced paper, right? Right. Somebody asked, the chronic diabetes, can it cause early IUGR? What do you think? No. The reason is in the early part of the growth will not affect because the blood flow to the baby in the early part is enough. Once the baby grow, when the placenta insufficiency occur, because placenta will form after 20 weeks, then only your placental blood flow will reduce. So then IUGR will occur in the later POA. So then it's going to be a asymmetrical IgG. I think it's a good paper, right? Isn't it? It's a very good paper. So today I'm doing as a hybrid session with the live students. Not easy. Actually, it's not easy, but it's a rational paper. I think we had a 2 or 3 weeks leave, no? We didn't do paper for 2 or 3 weeks. No, most of the things has evaporated. Yeah, I know. So that's the reason I did that for continuous paper. Otherwise, what will happen? You people will forget everything. So I need to keep you awake. So we'll start this because as they announce the exam date, we'll do continuously. Otherwise, we will forget. Right? Okay, fine. So we'll start with SBA. Right? A 59-year-old woman or female underwent vaginal hysterectomy under spinal anesthesia. 4 hours later, complained of mild shortness of breath, sweating, and thirst. She is conscious and rational. Vaginal pack not blood strain. Blood pressure 90/60. Pulse rate 180 per minute. Urine output since surgery is 20 ml. What is the most likely cause? So when you read this kind of question, you need to gather the information and rationally think. Then only you can come to the diagnosis. So what is the answer for this first question? Yes. High spinal. Oblique lie and unstable lie is not same. Oblique lie is one lie. Unstable lie is the lie is changing to time. Both are different. So actually, this question is bit confusing question. So among the answer, we will come to the answer later. First, you need to understand what could be the reason for this presentation, right? So here they have mentioned a 59-year-old woman. She underwent vaginal hysterectomy under spinal anesthesia. She underwent vaginal hysterectomy under spinal anesthesia. 4 hours later, she complained of mild shortness of breath. So it's mild difficulty in breathing, and sweating, thirst. So difficulty in breathing means maybe tachypnea. So the tachypnea, thirst, and sweating. So she is conscious, rational, and vaginal pack not blood strain. It means she doesn't have a bleeding outside. Blood pressure is 90/60, hypotension. Pulse rate is 108, tachycardia. Urine output is 20, oliguria. Right. So considering these features, oliguria, tachycardia, hypotension, tachypnea, thirst, sweating. These are suggestive of hypovolemic shock. Yes. Hypovolemic shock. Right? These are suggestive of hypovolemic shock. So the diagnosis is hypovolemia, maybe internal bleeding, or maybe some other reason. It's hypovolemia, right? So if it is a hypovolemia, what could be the cause? High spinal block, paralytic ileus, inadequate analgesia, silent MI, reactionary bleeding. So obviously silent MI gone, inadequate analgesia gone, paralytic ileus gone. So you might confusing with high spinal block or reactionary bleeding. So the problem with the reactionary bleeding, so immediately after the surgery, if someone is bleeding, that is primary bleeding. Mean slipped. So after putting the slip stitches, bleeding from the vessels, that is primary bleeding. What you understand by reactionary bleeding, the reactionary bleeding is, right? The reactionary bleeding is after you cut something, right? they might have some kind of inflammation or edema formation or something reaction to the surgery which cause bleeding. That is reactionary bleeding. That usually start for some time after the surgery, right? Okay, here this patient develop all kind of symptoms after 4 hours of surgery. So that is the controversial thing. So if somebody develops symptoms after 4 hours, usually the spinal effect will be reduced after 4 hours. The spinal effect will be reduced after 4 hours because that has half-life. But this patient develops symptom after 4 hours. So if somebody develops symptom immediately after the surgeries, then it could be due to spinal. Here, it's after 4 hours means when compared to these two factors, what is most likely? Most likely it's reactionary. Even though it's after 4 hours, you might ask, it's not enough time for the reaction, but still among these two answers, the reactionary hemorrhage will be the most suitable than the high spinal. Because after 4 hours, she develops autosopia. Do you understand? After 4 hours, she develops symptoms. So she became, after surgery, 4 hours, she was okay. After 4 hours, suddenly she developed, means she started to bleed now. Right. So somebody asked, but vaginal pact not blood stain. Yes, of course. The bleeding is inside. So it's an intra-abdominal bleeding. It's a concealed bleeding. That's why you couldn't see a bleed outside. Right? You couldn't see a bleed outside, but something is bleeding inside. So among these answers, the reactionary bleeding will be the suitable. So you should know why we are rejecting one answer. We are rejecting the high spinal because it starts after 4 hours. That is one. Right? And second thing, hypotension with tachycardia. Hypotension with tachycardia. Right? So if it is a high spinal, so thoracolumbar is a sympathetic nerves. So if the spine is going and blocking the thoracic nerve root, what will happen? Your sympathetic outflow will get blocked. If the sympathetic outflow blocked, what will happen to the heart rate? Will come down. So then you can't explain that tachycardia as well. So the most likely answer is going to be reactionary bleeding. So the answer is E. Answer is E. Right. Question number 2. A 35-year-old female who inserted with copper IUCD 6 months before. She is complaining of missing the thread. Speculum examination revealed no thread found. What is the next step of management? Yes. Yeah, it's simple, no? Because if the thread is missing, our worry is whether thread is expelled out or the IUCD is expelled out or still inside. How to check whether IUCD is in situ or not? We need to do the transvaginal scan to check whether the IUCD is in situ or not. So the answer is D. It's a straightforward question. It's not that much difficult. Question number 3, a 55-year-old postmenopausal woman presented with a single episode of vaginal bleeding. She found to have healthy cervix and normal size uterus. On TVS, there is 10 millimeter thickened endometrium and ovaries were normal. What is the most appropriate next step of management? Simple, yes. It's biopsy, right? Because postmenopausal bleeding, endometrial thickness more than 5 millimeter, you need to exclude the endometrial CA. There is no question on that. There is no question on that. You need to exclude the endometrial CA by assessing the endometrium. So the biopsy is the answer. So answer B. Question number 4, a 70-year-old woman with vaginal discharge has 3rd-degree UV prolapse with large decubitus ulcer. What is the most appropriate management? Broad spectrum antibiotic, Manchester repair, sacrohistopexy, VHLA, vaginal ring pessary. Right. So here, what do you understand by decubitus ulcer? Why we are having decubitus ulcer? When the uterus is hanging on the vascular pedicle, right? Hanging on the vascular pedicle, your venous vessels will get compressed, but arterial blood flow will continue to flow. So the blood is going to accumulate in the uterus, the cervix. Due to venous congestion, patient will develop ulcer, like in your varicose ulcer. So when somebody has ulcers and infections, she's having infection features, large decubitus ulcers with pervaginal discharge. When somebody have infection, is it possible to do the vaginal hysterectomy? Obviously no, because the inflammation, infection, the finding the plane is difficult, right? And the risk of peritonitis, and also you are not supposed to do the vaginal hysterectomy when somebody has infection and ulcer. So then what you have to do is you have to release the congestion to heal the ulcer. So then how can you release the congestion? You have to replace the uterus to the normal position. Temporarily, you have to replace the uterus to normal position. That is the first appropriate management for her. Now, you can't do vaginal hysterectomy right now. Now you need to do the treatment for ulcer, correction of ulceration. Once the ulcer corrected, once the infection corrected, then only you need to go for a vaginal hysterectomy. So for this condition, the most appropriate answer or management for this patient is vaginal pessary rather than hysterectomy. Right? You have to replace the uterus to the normal position, heal the ulcer. Once it heals, then only you can do the vaginal hysterectomy. What is the definitive management for this patient? What is the definitive management? Yeah, what is the definitive management? Shabana? The definitive management is vaginal hysterectomy. Right? That is the definitive management. There is no question on that. You need to do the vaginal hysterectomy. But for this patient, we have to take it as vaginal ring pessary. Okay. Question number 5. A 30-year-old woman who has family history of ovarian cancer presented to you. What is the best option to predict the risk of her cancer? It's simple, no? So if it is a familial cancer, there are few familial cancers. One is Lynch syndrome, second one is BRCA. So you need to assess the Lynch gene as well as the BRCA gene, HNPCC link gene or BRCA gene mutation. If they have BRCA gene mutation, then they are high risk to develop ovarian CA. So to predict the risk of malignancy, we need to check for the mutation in particular gene mutation. So the answer is mutation in BRCA1 and 2, right? If the BRCA1, 2 gene mutation is there, then the risk of malignancy is there. Then you have to do the prophylactic oophorectomy. So there is a famous actress did that, no? Who is that? Who is that? Angelina Jolie. Yes. She did the prophylactic mastectomy as well as oophorectomy for the prevention, as she has gene mutation. Isn't it? Right. Okay. So question number 5, answer is D. Question number 6, a 60-year-old patient presented with blood-stained vaginal discharge and vaginal itching. What is the next step of management? Now, patient came to you saying, doctor, I'm having discharge and itching. So what is your first differential diagnosis? It could be an infection. So how can you confirm the infection? How can you take the sample to confirm the infection? You need to put the speculum and see whether cervix is inflamed. Is there any discharge? What is the odor of the discharge? And you can take the high vaginal swab and send for the biopsy or not assessment. Then you can confirm the infection. So answer is examine the cervix with Cusco speculum. That's the answer D. Actually, this SBAR is very straightforward, but you need to carefully read, right? A 22-year-old female present 2 months before her marriage, right? So 22-year-old female, present 2 months before her marriage. Okay, right. Which question we have done? Question number 6. Okay, right. So, okay, here the question number 7. A 22-year-old female presented 2 months as before her marriage. She wanted to avoid the pregnancy for 6 months. The menstruation is regular, but she has dysmenorrhea. No past medical history. BMI 22. What is the most appropriate method? Yeah, what is the most appropriate method? So the considering uh, all the factors, the COCP will be the best option for her, right? Because she's young, going to marry in 2 months, and only she need only she needs 6 month period. It's very short period, right? So she doesn't have any menstrual irregularity, but she has dysmenorrhea. So your contraception should substrate the pain as well. So that is the second advantage. And no past medical history, BMI normal. So the best option is going to be OCP, right? So why not E? Yeah, there are so many reasons. One, then the implant, OCP will reduce the dysmenorrhea. Implant will not reduce the dysmenorrhea. So you need contraception as well as treatment for the dysmenorrhea. So OCP is best. That is one. Second thing, this is going to be for a 6 month period, not for the long period. So the implant is a bit expensive. For the short period, for the 6 month period, wasting this implant is not going to be the best option. OCP is just 100 rupees. The implant is going to be for maybe 15,000, 20,000. So for the 6 month purpose, don't use that. So cost effectiveness. But when you prescribe the OCP, especially for this patient, what you have to advise to the patient? Compliance. You need to advise regarding the compliance. If she forgot a tablet, then there is a risk of failure. And that is the only problem. But considering the other factors, the best option is A. Right. So the answer A. Question number 8. A 30-year-old female with primary subfertile for 4 years has undergone mammectomy 2 years back. What is the first line investigation? This is a straightforward question. If somebody undergo mammectomy with subfertility, what is the next investigation we need to do? What is the investigation we need to do? HSG. We don't do the invasive surgery because after mammectomy, there is a risk of tubal occlusion. So you don't need to go for an invasive surgery like lap and dye. So to assess the tubal patency, you need to do the HSG after mammectomy. So always we do HSG after mammectomy. So the answer is A. Question number 9. A 48-year-old woman with dysmenorrhea and menorrhagia come as complex glandular hyperplasia with atypia. What is the best option? Patient has atypia, hyperplasia with atypia. What is the best option? There is no question. So if it is a atypia, the risk of malignancy is high. Malignancy in 20 years is 20 to 50%. Associated malignancy risk is 43%. So always, if it is a atypia, you need to remove the uterus. But before you remove the uterus, you need to consider whether patient has fertility wish or not. Now she is 48 years, perimenopausal woman, right? And she is having atypical hyperplasia. What is the best option? You need to remove the uterus, right? So you can remove the ovary or you can preserve the ovary. That's after discussing with the patient. But TAH will be the option for atypia. So answer is D. Ovary remove. Yeah, ovary usually you can remove. As it is 48 years, you can remove it, right? Because there is a high chance of associated malignancy. 43% of mothers might have malignancy. If it is a malignancy, always you have to remove the ovary. There is no question on that. Right? So we have to do the TH plus BSO. Right. Right. Somebody asked, in 8 question, first line investigation, why not day 21, then HSG? No. No, here the problem is, if you do the myomectomy, will it affect the ovulation? No. The first line investigation, after the myomectomy, you have to check the patency. That's the first thing. Right. Question number 10. A 37-year-old patient presenting with chronic pelvic pain and dysmenorrhea. She does not have fertility wishes. On investigation, there is 10 into 7 centimeter right-sided endometrioma was diagnosed. What is the best treatment option? Yeah, what is the best treatment option? So somebody say A, because as they don't have fertility wish. Of course, they don't have fertility wish. So if somebody doesn't have fertility wish, are you okay to remove the uterus and ovary? No. Because the uterus and ovary is not only for the fertility, also for other functions, like hormonal function. So she's very young, 37, right? She doesn't have fertility wish, okay. But she's very young. If you remove the TH and BSO, if you remove the uterus and ovary, then what will happen? She will develop premature ovarian failure, so premature menopause. Then it's problem. So we don't do TH, BSO as a first line treatment. We try to preserve the ovary for the hormonal function. That is the first aim. We try to preserve the ovary for the hormonal function. Here, nothing with the uterus. In endometrioma, uterus is normal. It is an organ. Only problem with the ovary. But if you remove the ovary, no point in keeping the uterus. That's why we do TH plus BSO. But for 30-year-old woman, are you going to remove the uterus and ovary? No. Even though she doesn't have fertility wish, we try to preserve the ovarian function. So you need to preserve the ovary. So if you suspect the malignancy, then you can remove the one side ovary. So as it is endometrioma, is it a malignancy? Endometrioma, is it a malignancy? No, it's not malignancy. It's a benign blood collection. So if it is a benign blood collection, if you want to preserve the ovary, what is the treatment then? You need to remove the cyst only. Because this is benign, you need to preserve the ovary. So then what you want to do? You want to preserve the ovarian function. The first line is going to be cystectomy. If the patient has recurrent and lot of quality of life assessment, if the patient requests for the TH-BSO, then only the last option is going to be TH-BSO. So here they just mentioned patient has chronic pelvic pain, dysmenorrhea, does not have fertility wish. So what is the treatment option is ovarian cystectomy will be the first option. Then only the last option is going to be the TH plus BSO. The answer is C. Question number 11. You are called to deliver a baby with shoulder dystocia. The midwives have already put the patient in macrobot position. What is the next step? It's very tricky question. Yeah, most of the questions are, it's look like a easy question, but it's really difficult question. The typical female question. It looks easy, but it's really not easy, right? Isn't it, Lasanda? Am I right? So one day all the girls will hit me. I know that. It's okay. Right. So the shoulder dystocia, they have put the patient in the macrobot position. What is the next step? Always macrobot position. Next is suprapubic pressure. That is the first line treatment, right? So if macrobot, suprapubic pressure fail, then second line, your internal Manovir. If second line Manovir fail, Then third line. What are the third line maneuvers? Yeah, Pragit? What are third line maneuvers? Cleidotomy, symphysiotomy, Savanelli maneuver. Push the baby in and do cesarean section and deliver the baby. That is Savanelli maneuver, right? So those are the third line maneuver, right? So always, if the patient already put on Macrobot, what is the next step? Definitely, it's going to be suprapubic pressure. Question number 12. A 28-year-old woman had rapidly enlarging vaginal hematoma following ventrous delivery. Her vital signs are within the normal limit. What is the best step in the management? What is the best step in the management? So if it is a hematoma, what is the meaning of hematoma? Inside the tissue, the vessels got rupture and blood is accumulating. Inside the tissue, the blood is accumulating. So if you are not open the hematoma and arrest the blood vessels bleeding, the bleeding is going to continue to accumulate. So then what you have to do is you have to explore the hematoma and arrest the bleeding. That is the definitive management. There is no question on that. Right? So the vaginal packing will not help because the bleeding is inside, not the outside, inside the tissue. Right? So the answer is explore the hematoma. So if as this patient is stable, if they mention enlarging hematoma, patient is hemodynamically unstable, what is the next step? Resuscitation. Give blood, fluid. That is the first step. As this patient is stable, now you can do the definitive management, exploration of the hematoma and arrest the bleeding. That is the answer. So answer is B. Question number 13. A mother with past LSCS in second stage of labor for half an hour. 2/5 of the fetal head is palpable abdominally and now complain of severe abdominal pain. On examination, fetal tachycardia. Vaginal examination show tinkling of fresh blood. Most appropriate next step of management. Yeah. What is the diagnosis of this? What is the diagnosis? Uterine rupture. Pars section. Now continuous abdominal pain, fetal tachycardia, pervaginal bleeding, all are suggestive of uterine rupture. If it is a uterine rupture, what is the next step? Do emergency laparotomy. There is no question on that. You can't wait here. Now, the category 1 emergency cesarean section. Right? What you understand by category 1 cesarean section? The baby should be delivered within 20 minutes. Right? Within 20 minutes. So you need to deliver within 20 to 30 minutes, you need to deliver the baby. So the answer is B. Right. Question number 14. A 24-year-old prima gravida in 33 weeks of POA presented with severe frontal headache, vomiting. Blood pressure is 140/95. Reflexes are exaggerated. 3 beats clonus present. What is the most appropriate next step in management? So what is the diagnosis this one?
Severe preeclampsia.
Severe preeclampsia, right? So severe preeclampsia. Here, this patient has severe preeclampsia. That's why patient has elevated blood pressure, preeclamptic symptoms. So it's severe preeclampsia. So if it is a severe preeclampsia, as we know, we have 2 complications. One patient might have risk of intracranial hemorrhage as well as fits. Right? So here this patient has 2 complications, life-threatening complications. One is risk of intracranial hemorrhage, second one is fits. Among these 2 complications, which one is more high risk for this patient? Obviously, the fits, because the mean arterial pressure is not more than 125. If the mean arterial pressure is more than 125, the risk of ICH is high. The blood pressure is not that much high, 140/90. It's not that much high. So she has high risk of fits than the ICH. So the next step is going to be prevention of fits. After that, you need to give the antihypertensive. Do you understand? So how can you prevent the antihypertensive fits? You have to give the max sulfate. So answer is C. So these are very simple questions, right? So 18-year-old primary mother, 9 weeks POA, found to have a complete mole. What is the least important investigation in management of this patient? What is the answer? Yeah, ultrasound liver, because chest X-ray has to be done because the molar pregnancy has high risk of embolization and cannonball appearance in the lungs. That's why we are doing the chest X-ray. Full blood count, obviously molar pregnancy, when you do the suction evacuation, the hemoglobin should be optimized. So full blood count is important. Serum beta HCG, yes, because for the follow-up and things, we need to know the baseline beta HCG. There is no question on that. Ultrasound liver, that is not very important investigation for the this one. Histology, yeah, that is the diagnostic method. Histology is important one. So the least important is ultrasound liver. What is the best out of this? Of course, histology. That is the definitive diagnosis. There is no question on that. Right? Okay. So answer is D. Question number 16. A 31-year-old patient with seizure disorder comes to your clinic with her husband telling that they want to have baby. She is currently on phenytoin, regular dose, no recent fits. How will you advise her? Okay. If somebody has on fits, you have to have 5 things. I told you. What are those 5 things? What are those 5 things? Suitability for the pregnancy, disease optimization, drug optimization, endogen damage, and finally counseling. Right? Here, she had a fits, but not recent fits. So then she can become pregnant. It's not a big deal. Second thing, you need to assess whether the drug is okay or not. Phenytoin sodium, yes, we can use. We can use during pregnancy, so she can become pregnant. There is no problem. But the dose of the right, done. So dose of the phenytoin should be adjusted when she become pregnant. Okay, so that part should be done by the neurologist, not by us. It should be managed with the multidisciplinary team. So you need to get the opinion from the neurologist for the dose adjustment. And also, as she requests for the baby, we have to give folic acid, not 1 milligram, 5 milligram, because most of the anti-epileptic drugs are antifolates, high risk of neural tube defect. Okay, so the folic acid should be given not 1 milligram, 5 milligram. So most of the people will not notify that 1 milligram business. Folic acid, they are happy. So this is how you do mistakes. That's why I'm telling, whenever you read question, you have to read the question very carefully. Don't skip any word. Every single word is very important. Do you understand? So when I'm seeing the answers of most of the students, they do mistake because of this small careless. Do you understand? Because they know if no fits, if the patient is on phenytoin, she can become pregnant. You can reassure and give folic acid. That is also correct. But the answer, they mentioned 1 milligram supplementation. That's why it's wrong. Right? So obviously we need to get the opinion from the neurologist. So that will be the answer. So avoid pregnancy, no need to avoid. She can become pregnant. Delay pregnancy for 1 year. No, you don't need. Increase the phenytoin dose. That is not your work. Go for a pregnancy with 1 milligram folic acid supplementation. No, that's wrong. refer to the neurologist. That is the best answer. So if you are really understand the question, if you are really identify the problem, as I told you, the answer will blink. You don't need to worry. There won't be any complications. But if you read the question partially and if you are going with the intention of uh, 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 remembering the question, then definitely even God will not help you. Okay? So that's the thing. Always, when you come to the clinicals, when you come to the Viva class, you will realize what we are studying is correct or not. Okay, fine. Yeah, you know, so you are correct. Now you all are blinking. The answers are not blinking, you all are blinking, right? Okay. So question number 17. 26-year-old mother is in her second pregnancy. Her first child was born vaginally at a birth weight of 2.3 kilogram at period of gestation of 40 weeks. Now, she is 36th period of gestation. Symphysiofundal height is 32. What is the strongest indication for urgent delivery? Now, what are the information you need to gather from this question is, she is 26 years, second pregnancy, first baby 2.3 kilo. It means previous low birth weight baby. Right now, 36 weeks symphysiofundal height is 32. So what do you think about the symphysiofundal height? Is it adequate or less? Again, it's less. So it could be a IUGR. So the previous IUGR, again, second baby also, risk of IUGR, again, she's having IUGR baby this time. Now, while they are assessing, they want to deliver the baby. What could be the reason? Lack of fetal movement for 3 hours. For lack of fetal movement for 3 hours is not an indication for early delivery or emergency delivery. Lack of maternal weight gain for last 4 weeks, we don't worry about that. If it is a lack of fetal weight gain for last 3 weeks, yes, static growth for 3 weeks is an indication for the delivery, not the maternal one, right? Amniotic fluid index is 7 centimeter. That is actually normal. No need to deliver immediately. Elevated uric acid level, that is not indicated for delivery. Lack of variability in CTG for 90 minutes. So we studied in CTG class, reduced variability up to 40 minutes, it's normal. From 40 to 90 minutes, it's non-reassuring feature. If it is more than 90 minutes, that is abnormal feature. This is how we categorize the CTG. So here they have mentioned lack of variability for 90 minutes, almost abnormal feature. So already baby is compromised, IUGR. So compromised baby with abnormal CTG. Will you keep the pregnancy or deliver the baby? What do you think? Compromised baby with abnormal CTG. Immediate delivery. Otherwise, baby will die. Immediately you need to deliver. Right? Immediately you need to deliver. Right? Okay. So the answer is E. Question number 18. A 21-year-old primey presented with acute onset of shortness of breath at 24 weeks of POA. Pulse rate is 140. Irregular. Respiratory rate 22. Blood pressure 100/70. SpO2 92. Low pitch mid diastolic murmur in mitral area. Bilateral fine inspiratory crepitations. What is the drug of choice? First line drug of choice. What is the diagnosis this one? Tachycardia, irregular pulse, shortness of breath. Yeah?
AF.
Actually, mitral stenosis complicated with atrial fibrillation, now complicated with heart failure. Right? So because of the mitral, that's why in mitral area, mid-diastolic murmur. Mitral stenosis is a risk factor for atrial fibrillation. That's why you get a irregular pulse. If it is a irregular pulse, atrial fibrillation, that is a risk factor for heart failure. Now patient has heart failure. That's why patient has bilateral fine crepitation. So left heart failure, atrial fibrillation, mitral stenosis. So these are the three problems she is having. Among these three problems, which one you will address first? Heart failure, AF, MS. Which one you will address first? Heart failure. There is no question on that. First step, you need to do something for the heart failure. Then you have to control the control the rate control, right? Then rhythm control. So you might be knowing these things you studied in medicine, this one, right? So heart failure treatment, rate control, rhythm control. Sometimes you can control the rate and rhythm with the drug, amiodarone, or maybe sometimes you might need electrical, isn't it? So that's depends. DC. So here the first step is heart failure management. So what is the heart failure management? Furosemide, right? So furosemide, that is the first step. Because her SpO2 is 92. Gas exchange has been reduced. So if you are giving rest of the treatment without oxygen, then patient will die. So first you have to increase the oxygenation, then only you have to go for a definitive management. So what is the next step? So these are very simple thing, right? It's a very simple thing, but you are not thinking in that way. So the answer is diuretic. So really speaking, this paper is very standard paper. Right? So not very hard, not very easy. It's a rational thinking and application of your knowledge. If you don't understand, you can't apply your knowledge. Do you understand? Okay, right. So question number 19. 19-year-old primary mother is in active phase of first stage of labor. What is the best parameter to assess the progression of labor in first stage? What are the parameters we are using to yes, Charita, yes. What are the parameters we are using to assess the progression of labor? There are two things. What are those two things? One is dilatation of the cervix. Second one is descent of the baby. Dilatation of the cervix and descent of the baby. Among these two, what is the best one? Is dilatation. Next is descent. So it's a straightforward question. So 19-year-old primary, she is in labor. How you are going to assess whether she is progressing or not? You need to assess the dilatation. Depend on the dilatation only. We are drawing the action line. We are drawing the alert line. On the basis of action line and alert line, we are managing the patient. Do you understand? So the answer is B. Question number 20. A woman with type 2 diabetes mellitus presented at 8 weeks of gestation. Which of the following investigation is most predictive of fetal outcome in this patient? I think I have done this one and I have I taught you in the theory class and all. Yes, Prahalada, what is the answer? Yeah, if you mark it wrong, then I'll scold you. Right, fine. So the fetal outcome in chronic diabetes is depend on the glycemic control. Glycemic control. So what is the best way to assess the glycemic control in a chronic diabetic patient is HbA1c. HbA1c, because your postprandial, blood sugar series, fasting, everything will assess the day before the food, the day on the day of the blood sugar. But the HbA1c will assess the long-term control. So we are assessing the suitability of pregnancy with the HbA1c. If the HbA1c is less than 6.1, we are happy. The risk of complication is less. If the HbA1c is more than 610, the risk of congenital abnormality is 15%. It's contraindicated for pregnancy. So the HbA1c is used to assess the suitability of pregnancy. That will tell the risk of congenital anomaly in chronic diabetes. So answer is B. So now you might understand the importance of rational thinking, and as I told you, I am going to train you how to do the paper within a time. So so next step for the exam, for the exam preparation, what we are going to do is we are going to do the paper on time. So please, so this is for you, not for me, right? So if you really want to train yourself, if you really want to assess yourself, so I'll send the paper on Thursday, 7 p.m., 9:30 p.m. You need to send the answer sheet, right? You will get the mark sheet later. So then Friday 12:15 to 4:15, I will discuss the paper. So we will discuss like this: 25 MCQ, 25 SBA. So most of the questions, concept will be recur in your exam. That is different issue. But I will not say the question will come. Question will not come, the same concept. But you need to understand that concept, because now most of the students did the wrong answers, because I know they know the stuff, but most of the people did careless mistakes because you are not reading the question properly. Please take your time, read the question carefully, apply your knowledge, find out the answer. Don't miss this exam. That is the highlight point, because this is like very rare things in the world, having the ERPM exam. So if you miss this time, so then you may have to wait for, we don't know when will be the next exam. So please prepare maximum and get through the exam this time. Okay, so if you have any question, you can ask, or otherwise, we have done the paper without tea break, I know, but it's okay.
Sir, I have a question.
Yes, welcome.
The question number 8, the 30-year-old with primary subfertility who has undergone myomectomy. We chose HSG because it's non-invasive, the first line investigation, is it?
Yes.
And not Lapandai because it's invasive, even
Yes.
though we can do adhesolysis.
Yes. Yeah,
Okay.
that's the reason.
Okay, thank you, sir.
How long we have to be fit free to be become pregnant? 1 year. So if it is a epileptic patient, if fit free for 1 year, then you can even the guidelines said even you can stop the treatment and she can become pregnant, right? So that's why we need to get the neurologist opinion.
SBA 8.
Yeah.
I have another question. Because he suffered it for the 4 years, no?
Yes.
Then after that he going for the myomectomy.
Yes.
So she already suffered it before the myomectomy. So better to do day 21 progesterone.
No, it's not like that, because before they go for an invasive surgery, they might exclude the ovulation first. Now the question is, after she's a subfertile patient, they did the myomectomy. Now what you are going to do next step? Do you understand? So then we need to assess the patency. So we are not going to do the retrospective things, right? So if you answer like day 21 progesterone, that is saying after myomectomy you want to reconfirm the ovulation again. Do you want to reconfirm the ovulation again? No need. Now you want to reconfirm whether tubes are patent or not. If the tubes are patent, then you can start the treatment. That's it. So if you ask the question, so for subfertile patient, 4 years, found to have fibroid, but it's the first line treatment, then day 21. If the patient doesn't undergo myomectomy, first time she came to you, she's having fibroid, okay. But what is the first line? First you exclude the common cause anovulation. So you first exclude that, then you can go for a myomectomy part. But this patient already they assess and they did the myomectomy. Now they're asking, what are you going to do now again? That will be the HSG, not the day 21 register. Okay?
So true false question number 15. Uterine septa may cause abnormal lie but not unstable lie. So is it true or false?
Which one?
True false 15.
15, yes. Uterine septa.
It can cause abnormal lie, but can it cause unstable lie?
No, it can cause unstable lie as well, because as it depends on the uterine septum location. So if it is a transverse septum, then it will be abnormal eye, persistent abnormal eye. But if the septum is in the lower part, then baby might turn like a placenta previa. So it can cause unstable eye as well as the abnormal eye as well.
Okay.
So what you understand by unstable eye, so the abnormal eye change day to day.
Time to time. Okay.
Yeah.
Thank you.
Okay. In question 10, any consideration regarding the size? SBA or MCQ?
SBA, sir.
No, the consideration regarding the size, will you do the cystectomy or not? If the cyst is more than 3 centimeter, you need to do the cystectomy. If the cyst is less than 3 centimeter, you don't need to do the cystectomy. That is the size of consideration. Why? The reason is, if it is more than 3 centimeter, you need to do the cystectomy, and cyst wall should be sent for the histological assessment. There is a small possibility of endometrioid malignancy risk. That's why we have to do the cystectomy and histology assessment if it is more than 3 centimeter. In PPRN, if a mother and baby is stable, IV benzodiazepine or oral erythro is better. Don't ask this kind of question. Always oral. If it is a prophylaxis, we don't give IV. It's oral.
SBA 10, they ask best treatment option. No? So TH plus BSO is the best one. No?
No, we can't
Other
say.
thing is
No. We can't say what basis we are deciding whether it's best or not on the patient interest. So in patient side, here of course you need to treat the endometrioma. Same time you need to consider about the premature ovarian failure as well, or premature menopause as well. So the definitive treatment is obviously TAH plus BSO, but best one, it can't be a best one, can't be a definitive one. Best treatment and definitive treatment is different. Best one is, which one is better? THBSO, of course, if you do THBSO, you might think it's better, but if you do THBSO, what will happen? Patient will develop menopausal symptom. So then it can't be best one.
After 1 year, we can do hormone replacement therapy. No?
No, the thing is, hormone replacement therapy has a lot of side effect, right? So if you do THBSO, something is better than nothing. That's why we are giving hormone replacement therapy. So when you plan the management, you have to assess the risk and benefit and decide which one is best. Do you understand? Here, which one is best? So you are deciding the best treatment depend on the risk and benefit. That the best treatment always can't be a definitive treatment. Do you understand? Right. So in question number 13, till we do the emergency cesarean section. Most appropriate next step of management. Okay, what is the next management you are telling? Question number 13. If you say saline and observe, no, you can't observe because already uterus ruptured. Are you going to observe until she died? Still alive, still alive. Ah, done, finish. Confirm the death. Is that so? No. So we are not going to observe. So you need to do adequate pain relief. Of course, pain relief is not the treatment here, no? Right? So, adequate hydration. The hydration is not the appropriate treatment. Of course, you need to hydrate to resuscitate the patient, but the most appropriate treatment is delivery. Left lateral position and give oxygen the patient. So here we can't give those ones. Perform emergency category 1 cesarean section is the answer. Question number 3, CA1 to 5. What is that? So, question number 3, CA1 to 5. Why are you asking this question? So what is endometrial CA? Will you have elevated CA1 to 5? Huh? No. Don't ask a question like this. Yeah, why can't we oophorectomy? Yeah, no, the thing is very minimal risk of oophorectomy, ovarian CA. So then now the aim is to preserve the ovarian function and remove the cyst. That is the aim. That's why we take it as cystectomy. So if they mention multilocular cyst, 10 centimeter, no fertility wish, then what is the management? Then oophorectomy, because that is not endometrioma. Multilocular cyst could be malignancies, we don't know. But here they have mentioned it's endometrioma. For the endometrioma, you don't need to do the oophorectomy. One ovary removing, okay, right? It's like that. So if you want, you can remove, but you can't say, do you have two? No, then we'll remove one. So then everybody can donate one kidney, no? You have two, why you are keeping two? You can give one. It's not like that. So better to keep both, but if needed, then you can take one. Right, okay. So if diagnosed plexanophilia at 32 weeks, will the position change at 34 weeks? Usually not. Very less likely to move after 32 weeks. Right? It's usually not. Okay. Thanks
Excuse
a lot.
me,
Yes.
SBA 19. SBA 19. Could you explain, sir?
Why? What's the problem with the 19? So the progression of the labor can be assessed with the descent and the dilatation. Among these two, which one is best? It's the dilatation. Dilatation is the best one, because that's why we use this action line, alert line, and all kind of things. Second one is descent. Both are used to assess the progression. Among these two methods, the dilatation will be the most suitable method.
Thank you, sir.
Okay. Right. So we'll stop with this. We'll meet next week. Okay. Bye. Okay. Bye.